of having virtual meeting for a very long time, we will not be able to discuss. But if we get time, we'll go through the DST from Shauri Moyo, the DST results alone, not the whole case because of time. So I will welcome Dr. Nyukuri to take over the meeting. And for those, as we continue with the discussion and the presentation, you can be typing your questions on the chat box so that we be able to capture them early and we finish in time. So welcome, Dr.
Thank you so much, Chris, for the wonderful work you're doing. Good morning to all of you, and welcome to our monthly TWG meeting. Today, we are going to discuss a topic that is very important to our work as a TWG, and this is a review and management of patients who are failing second line, and we will mainly focus on the drug resistance mutations. Of course, we know failure has other components, including adherence and so on, and that can be handled in a separate forum due to time constraints. So, So this is a typical case. This is a case that we had at Kenyatta National Hospital, and I just thought maybe I'd borrow it and use it as and just present it so that we get an idea of the kind of patients we are going to deal with. So this is a 23-year-old male, non-RVD, since April of 2010. A very nice summary of the treatment regimen of the patient. Diagnosed in 2010. 2016 was initiated on Z3 nevirapine, the high viral load. Switched to efavirenz in 2017. As you can see, persistently high viral load for one reason or another. 2 years down the line, the team thought, okay, this patient is not doing well. Probably it's time to change to second line. Was switched to the recommended second line. And again, as you can see, the patient did not suppress. So in October, the team decided to do a DST. And it's a very interesting DST. You can see the NRTI patient had multiple mutations, NRTI multiple mutations. We're going to talk about these mutations later on in the presentation. Normally, this report comes with an interpretation. You can see the patient was resistant pretty much to all drugs except tenofovir, which also had intermediate resistance. Looking at the NNRTIs, also quite high level of resistance. PI also, the patient had 2 mutations which conferred varying levels of resistance to the PI drugs currently in use. And so you can see this patient actually did not have a single sensitive drug. So the question is, what are you going to do? And that is what this CME is all about. So for us to understand drug resistance mutations and in HIV, it's important for us to know about the life cycle of the virus. And this is just a reminder. I know most of you are conversant with the different stages of the life cycle of the HIV virus, from the entry of the virus to reverse transcription using the reverse transcriptase enzyme, integration into the host genome using the integrase enzyme, transcription of the viral DNA into the various viral particles using the host mechanism. Then these viral particles are cleaved and packaged using the protease enzyme. And finally, as you can see, this viral assembly and shedding. Why are these stages important? And this is because drugs currently in use work at these different stages of the life cycle. So the entry inhibitors, which currently are not in use in Kenya or commonly used in Kenya, the fusion inhibitors, these are the maravirox, the enfuritide, and so on. Reverse transcriptase inhibitors, these have been the cornerstone of treatment for a very long time. Integrase inhibitors, the new wonder drug in the market, and they are really, really, really potent. Maturation inhibitors, we have been using protease inhibitors for a while. Again, very potent and very useful. A new class is also coming, upseed inhibitors, which do inhibit the viral capsid that encloses the viral genome, and probably in the next couple of years, it will be in the market. So these are the drugs, and these are the various stages they do work in. So how drug resistance arises? You realize that in a population in a patient infected with HIV, this patient will have various strains of the virus. And some of those viruses will be susceptible and some of them will be resistant. And this occurs in nature, even in a patient who has not taken a single drug. There will be some viruses that will be resistant and some viruses that will be susceptible. And this is why HIV is not treated using a single drug. HIV is treated with drugs from 2 or more classes. That's because of the inherent resistance in some of the viruses. And you're going to talk about how this resistance arises. Imagine you're giving this patient who has 3 different strains. One strain is resistant to the drug. So let's say you're treating with a single drug. This single drug will inhibit or will stop the replication of these 2 susceptible strains. And then this resistant strain will remain. And because it has no competition, it will thrive and it will become the predominant strain. And once it becomes the predominant strain, then the presence of this selective inhibition, it can acquire other mutations and also become resistant to other drugs. So that's why we normally say that when a virus is resistant, especially to more than one drug, it has more than one mutation. That one is purely man-made. And how is it man-made? Because of selection of the resistant strain through giving drugs that do not stop replication of all the strains. And as we said, drug resistance can be acquired through the process I have just mentioned here. It can be transmitted. I mean, if somebody has a drug-resistant strain, that person can transmit strain to another patient. What are these factors that contribute to failure and resistance? We can classify them as virus-related factors, drug-related factors, and host-related factors. Remember, now, looking at the virus-related factors, remember it said that viruses in a patient, some of them will have resistance even before they encounter a drug. And why does this happen? This is because the virus has a high replication rate. I mean, probably this is close to 1 billion viruses replicated in a day. And the reverse transcriptase enzyme is error-prone. It makes a lot of mistakes. These mistakes are the ones we call mutations. And some of those mutations actually are the ones that confer viral resistance. And to a lesser extent, are the latent reservoirs of HIV, so that we know HIV hides in the long-living memory cells. So imagine a HIV virus that has already acquired mutation hiding in this long-living reservoir cells. That means that once you have acquired a mutation, it is lifelong. It is highly unlikely that you are going to reverse that process. And the more mutations you acquire, the more they are stored, and the more difficult it is to find an optimum treatment regimen in future. Looking at the drug-related factors, as we said, the drug is not able to inhibit replication of all the viruses, and this means the drug is either inadequate in potency, or the drug's durability is is short, or the drug-drug interactions that make the drug less potent, or the concentration of the drug in the body to be low. If the drug has a lot of side effects and therefore the patient is not able to tolerate it, or if the dosing is just inconvenience, BD, TDS, QID dosing are a huge inconvenience. And lastly, host factors, patients who are not adherent, and HIV requires you to be, almost 100%, if not 100% adherent. And also, if the toxicity that are specific to a particular individual, or an inconvenience that is specific to a particular individual, then this also will affect adherence and will lead to ARV failure and drug resistance. So when we are addressing drug resistance, or when you're addressing treatment failure, we need to address all these factors at the same time, so that we are able to put the patient on an efficacious regimen. So I know I mentioned something about mutations. So how do these mutations eventually lead to drug resistance? Remember, everything in your body is coded. If you have worked with computers, you code, and then the code will execute a function, and eventually we'll see a result. So your body has DNA, and this DNA are the codes. They contain codes for different things, for amino acids. So if there's a change in the code, which is what we are calling a mutation, then you are going to get a change in the amino acid that is coded. And when these amino acids aggregate together, they form a protein. So if there's a change in the amino acid, then definitely it will affect the protein. So either the structure or the function of the protein will change. And this protein can be a viral enzyme protease, or it can be a reverse transcriptase, and it can be an integrase, and so on. When the protein changes, that means that anything that interacts with that protein, that interaction will also change. So how this protein interacts with the drugs will also change. So if initially the drug was able to inhibit the protein, because of these changes, which started all the way from the mutation, it means that then the drug may be unable to inhibit the enzyme, and this is what we call resistance. Coming further to the mutations, so these are the codes I was talking about. Like AA will code for lysine, GSC will code for aspartate, I think. AGT will code for serine. So imagine now there's a mutation, so that this A is changed into C. So AAA is lysine, an amino acid called lysine. ASC is something different. I think I can't remember the exact name. So nucleotide change has caused a change in the amino acid sequence, right? And if the amino acid changes, then when these all amino acids that make the protein are put together, then you'll find that either the structure of that or the function of that protein changes. Now, not all mutations lead to a change. As you can see, AGT codes for serine, AGC also codes for serine. So some mutations are what we call silent mutation, and that's why when you see on the drug resistance table, they might put quite a number of mutations, but not all of those mutations are relevant. So we will only focus on the relevant mutations. Nomenclature of these mutations. So in the amino acid, we have the codons, and these codons are the ones that code for the amino acids. Yeah, so like the position 184. All right, at the position 184, we're normally supposed to have M, M184. But if there's a mutation, and then that mutation the M is replaced with V, then the mutant amino acid will be called 184V. So how we or how we name is at position 184, it's supposed to be M. But if there is a mutation that has changed this M into V, then the V is put at the end. That's why we say M184V at position 184, where M is supposed to be, has been replaced by a V. Sometimes you might find that it's more than a V. Maybe at 184, there are other mutants. Maybe it might be a normal and an abnormal. So some viruses might have the normal, some viruses might have the abnormal. We might have M184M and some have an M184V. It just means that there's a mix of normal and mutant viruses in that population. Sometimes maybe the M was in some viruses or is replaced with V, and in some viruses it was replaced with I. And then that's why we say M184V stroke I. So we have mutant populations in the patient. Again, you will hear terms called like low genetic barrier and high genetic barrier. It basically means that in low genetic barrier, you need only one change, just one change, and the whole protein changes, okay? So one amino acid change and the whole protein changes. For example, K103, which is an NNRTI mutation. Somebody with techno speaking, kindly mute. No speaking, kindly.
At least. Stress, the other one, that's a call of them.
Chris, are you able to mute people?
Yes, yes.
Please do.
Okay.
Thank you. So drugs that only require one amino acid change for the drugs to be resistant are called drugs with a low genetic barrier. All right. But like protease inhibitors, you require multiple amino acid changes before the drug is affected. Okay. And these are the drugs that we call drugs with a high genetic barrier. So looking at ARV potency versus the genetic barrier. So potency just means the ability of the drug to drop the viral load. By how many logs? 10 to 100 is one log. 100 to 1,000 is another log. 1,000 to 10,000 is another log. So very potent drugs include raltegravir. Efavirenz is pretty potent. DTG, darunavir, ritonavir, lopinavir, ritonavir, they're pretty potent drugs because they are able to drop the viral load by approximately 3 logs or more. If somebody had a viral load of 100,000, then these drugs are really able, just on their own, to drop from 100,000 to 10,000 to about 100. You see, dropping from 100,000 to 100 just on their own. So pretty potent drugs. But potency also does not equate to genetic barrier, because we'll find that certain drugs that are really potent, like these ones, but they only require one mutation and they're out, all right? And then some like Maraviroc, not very potent, but again, they have a high genetic barrier. That means they require a number of mutations before they become resistant. So as you can see, the drugs that we like DTG, has a very high potency and also has a very high genetic barrier. Same to darunavir, ritonavir, very potent, very high genetic barrier. Lopinavir, ritonavir, pretty high genetic barrier. Also very potent, but we know the challenges we have with this drug, especially in terms of the side effects and just the number of things that a patient needs to take on a given day. and so on and so forth. And that's why if you are coming up with a regimen, you try to use a regimen that has a very high potency and also has a high genetic barrier to resistance. So as I said, viruses that acquire drug resistance to one drug can develop mutations leading to multi-drug resistance. And when you continue treatment with a failing regimen, that means you have selected the resistant viruses. Whatever viruses are in the patient's body are the resistant ones. And these resistant viruses will acquire other mutations. And that is how a patient ends up with 5, 10, 15, or so number of mutations as the patient we have discussed before. And as I said, HIV does not forgive treatment errors, okay? Or non-adherence. Once you get a mutation, once you get drug resistance, it's likely to go and be stored in the latent cells, and it's for life. That class of drugs cannot be used in that patient for life. All right, so let's talk about now the drug resistance, the mutations themselves. There's this very nice what we call database, the Stanford database, that has all these mutations, and it enables you to maybe if you really want to go and check specific mutations, the explanations to the mutations, how they interact with each other. And I just thought here, maybe we can have an interactive exercise. So let me just go to the website itself. I'd opened it earlier. Just a minute. So that we are able to navigate through the website. This is a PowerPoint. Where is my... Oh, these things, when you want them, that is when they disappear. Yeah? I'm looking for, yes, here it is. So this is the website, all right? So when you go to hivdatabase.stanford.edu, or just type HIV drug resistance database, it will open this very nice website, okay? Please don't concern yourself with it. It can do a lot, but normally I just say this is the place of interest. So for example, if you want to know about the NRTI mutations, then you go to NRTIs and you click. When you click, it's going to open up this nice table. This nice table will basically show you what the mutations that are there and the effect of these mutations on the drugs. For example, maybe you want to know more about M184. So you saw from the results that the patient has an M184. So M184, if it's M184 is the normal amino acid. But if M has been substituted with a V or I, then you can see lamivudine is out, FTC is out. It affects also abacavir and didanosine. But this stars, it means it increases sensitivity. So it increases the sensitivity of TDF, D4T, and zidovudine, okay? If we take also another mutation, a common one like K65. Position K65, this is the normal one. If it acquires an R, so K65R will affect TDF, it will affect abacavir. It will also reduce the sensitivity to 3TC, but it will make zidovudine more sensitive, all right? And this is why we normally like using TDF as the first drug. If you use TDF as the first drug and you acquire the K65 mutation, if you are going to use zidovudine as the second line, then that's a good thing because zidovudine is going to be more sensitive, all right? And what do we mean by these different colors? Bold red means, it is high level mutation. Just a bold color means intermediate. A light color means, low level. And then the stars means it has the opposite. increased susceptibility. So we have what we call the thymidine analog mutations. The terms are normally selected by the thymidine analogs. The thymidine analog that we are currently using is zidovudine. Previously, we also used to have tavudine, which is currently not in use. And these terms also, we have term 1 and term 2, and probably I might mention them a bit later. Also, we have this, what we call MDR, multi-drug resistance mutations. These are nasty. These are bad. Okay, get a T69 insertion, and all your NRTIs are gone. Get a Q151, and all your NRTIs are gone. So when I see these two mutations, I just know we are in real problems. So apart from NRTIs, you can do the same for NNRTIs. You don't want to go to NNRTIs because we are facing them out. PIs also, as you can see, the 3 PIs, zanavir, darunavir, ritonavir, and lopinavir, ritonavir. For example, atazanavir, the most common mutation here, which you'll be aware of, is the I50L. This is what we call it signature mutation. For lopinavir, ritonavir, the signature mutation is this one, I47. If you want the explanation, of course, as I said, very nice explanation. It will tell you about the mutation and what the mutation does, and the effect of the mutation on the drug. Very, very nice website. All right, so let me go back to my presentation. All right, so at least we have had an interactive session where we have learned more about the database. And this is what I was just telling you about. I basically copy-pasted this from the website. So when I share the slides, at least you will know where this one came from. I mentioned something about the terms. We have term 1s and term 2s. For those who are really interested, you can dig deep and find out what term 1s, term 2s, and the effect. But to me, the take-home message is, you know, the mutations and the drug resistance they cause and the interaction they cause. And the good thing is, actually all the results come with an interpretation. So to those who are interested, this is important. To others, just go directly to interpretation of the resistance, which will be generated by the website. So let's come to now management of these patients. What are we going to do? As a team, you've discussed the patient. You've agreed that this patient needs to have a DST, collected the sample, sent it, the results are back. And you're asking yourselves, okay, which drugs are we going to use? So I've tried to simplify it. And to me, the first thing I normally ask myself is, do we have a fully active protease inhibitor? Because that changes a lot of things. Imagine this is the patient's results. RTI mutations are all these. So basically, the only drug here that you might think of is tenofovir with some low-level resistance. The PI, you might find that you only have one that is susceptible, like in this patient who had a darunavir, or you might find all are susceptible, right? So when will you get a situation like this? When you get all the PIs are susceptible, just know that your patient was not taking second line. And the answer is simple in this case. That patient on the second line he or she was on, and enhance adherence, because the issue there was just adherence and not the patient was not taking the drugs. However, if you get a scenario like this one, then when there is one or more mutations, PI mutations, then the best drug to use is darunavir, ritonavir, and it will be the last one actually to go in terms of mutations. As we saw, it has a very high genetic barrier. So as I said, if you have a fully active PI, Then what are we going to do? We are going to use 2 NRTIs and a PI, right? We are going to use 2 NRTIs and the fully susceptible PI. So if you have multiple PIs, then I'll prefer you use atazanavir so that darunavir is spared for future use. But if there are multiple drug-resistant PIs, then choose most susceptible, which is darunavir. Then you'll ask yourself, which NRTI will I use? Because if you look at this patient, almost all NRTIs gone. So which NRTI am I going to use with this patient? So this is where we had these 3 studies, which we have talked about for a very long time: the second line, the earnest, and the select. These are second line studies. So they were looking at the standard of care at that time. The standard of care at that time was lopinavir, ritonavir, and 2 or 3 RTIs. So they were looking at patients who had failed first line. So first line consisted of, let's say, AZT, 3TC, nevirapine, or AZT, 3TC parvirines at that time. They had not used a PI. They said if you are going to put them on second line, we normally use NRTIs that were not used in first line plus a PI. But we know that NRTIs have this cross resistance, as we have seen. If you have multiple NRTI mutations, they will even affect other NRTIs that you have not used before. So they thought, why not just, instead of using NRTIs, we use a totally new drug, so that we are going to have 2 totally new drugs, which is lopinavir, ritonavir, and raltegravir, right? And how are they selecting the NRTI? Same way we do. If you used TDF in first line, use AZT. If you used AZT in first line, use TDF. And the results were very interesting. For the patients who they used 2 new drugs, that is raltegravir and a PI, vis-a-vis the patients who they used the standard of care, which are 2 NRTIs plus a PI, in terms of resistance, it was the same, right? So in terms of the patients who failed the treatment, not much difference. In terms of side effects also, not much difference. And that's why I said then, if you have a fully active PI, you can use fully active PI and 2 NRTIs, which you will select on the basis of, if the patient had used this has not been used. Or if that is not possible, you can use a PI, the fully sensitive, and an INSTI. An INSTI now here is either raltegravir or dolutegravir. And since dolutegravir is more potent and the one that we have, that's the one that we use in this patient. So you see, if a fully active PI is available, it makes your work very easy. Now, you might ask yourself, so what if the patient had quite a number of mutations in the NRTIs? Will it affect the outcome? And the answer is no. In the earnest study, they looked at patients. The black line is patients who had 0 active NRTIs in the group. The green line is patients who had 1 active. The purple line is patients who had 3 or more drugs which were active. The blue line is, patients who had who are on the raltegravir and PI. And when you check the confidence intervals, not much difference. And also, we have raised a lot of issues about this group of patients who had 2 or 3 very fully active NRTIs, and they seem to be performing worse. But here, what the investigators postulated was, when a patient is failing treatment and the drugs are still sensitive, this patient was not taking the drugs, plain and simple. And because they had adherence problems in their first line, they continued with it in their second line. So when you get a patient and you look at the DST and the patient has a lot of sensitive drugs, that patient, it's adherence. Look more towards the adherence issues more than anything else. Right. What if you don't have a fully active PI? I have 15 minutes. If you don't have a fully active PI, look at this patient, right? So again, the NRTIs, varying levels of resistance. But this is a patient who first line used DF, right? And developed a K65R mutation. Second line, probably they went to AZT. The good thing is K65 and the terms really don't like existing together. So the K65 is protective. And that's why even after using AZ in second line, the patient did not develop terms. Okay, there's just one term I see at 19E, which is a type 2 term. So that's why the patient had a susceptible NRTI. So if you don't have a fully active PI, like this patient, nothing here is susceptible, and you have a susceptible NRTI, all right, which more often than not, it's going to be zidovudine in patients who were initiated on TDF before, and then they continued with AZT. Then use DTG as the 2 NRTIs, and 1 NRTI must be fully active. So here, this is a patient who has never taken DTG before, has this profile. So what are we going to do? We have one susceptible NRTI. We are going to use the susceptible NRTI. We are going to add DTG, which is also fully susceptible because the patient has never used it. Then you are going to add the third NRTI, which of course is going to be lamivudine, because we know the mutation that lamivudine confers is an advantageous mutation. So this is a patient I'll gladly put AZT, DTC, and DTG. And where is the evidence of this? The Downing study. So the Downing study also was looking at using DTG as a second line. And they said, okay, these PIs, can we do away with PIs as second line drugs? All right. So we know the standard of care is normally lopinab is a PI plus NRTIs. But here they replaced the PI with DTG. So you are on DTG as 2 NRTIs. But one of the NRTI must be fully active. And that's why I'm insisting on this. One of the NRTI must be fully active. And when they looked at the outcomes of these patients, and these are patients who had failed first line or on second line, the blue arm is DTG, the orange arm is the standard second line. It was superior, all right? It was actually superior to the standard second line. And therefore, if you have a fully active NRTI and the patient is insti-naive, throw in that fully active NRTI, add 3TC plus DTG, and that's going to be a wonderful regimen the patient will suppress. Now, if there is no active PI or NRTI, what are you going to do? And this is the patient you remember we had seen, yeah? The first case we had discussed. And this normally occurs in patients who were initiated on AZT as the first drug. That's why I don't like starting AZT as the first drug. So they were initiated on AZT, they accumulated all these mutations. So even when they were switched to a second line which contained TDF, even TDF here was not acting. You can see this patient does not have a K65R, which is the signature mutation for TDF. And then the PIs, because of these 2 mutations, even darunavir has low-level mutations. Now, these are the kind of patients who we scratch our heads. The good thing is the majority of our patients have not used, who are failing second line, have not used DTG. They have not used an insti. So in these patients, DTG must be there. So that's the first drug you are going to add. Now, we know in HIV, we need to use, if you can get at least 2 drugs from, which are fully active, and then you add other drugs, you are on the safe side. But we cannot get another fully active drug here, right? What are we going to do? Second thing here, you have to use your darunavir, right? It has low-level resistance, which is a good thing. It's not fully active. It has low-level resistance. If you double the dose, okay, you are going to use now 600 BD instead of 800 OD, which we normally use in patients who don't have any PA mutation. Then it's going to be really, really helpful. But we also know that we only have, one active drug. So we'd like to look for another drug just to strengthen this regimen, right? So which other drug has either low level or intermediate level resistance? So here we have etravirine and we have tenofovir. So what we like to do in such patients, you'll find that if you add TDF, 3TC and DTG, that's one pill. So already you are reducing the pill burden. So it's much better if you were to use TDF here than etravirine, which is a single drug on its own. And then 3TC, we know as much as there's high level resistance, mutation is good. If there is an M184V, it increases susceptibility to the tenofovir arm, and also possibly it makes the PIs more active. So in such a patient, then, as we said, a good drug here would be DTG, and then you add your darunavir. Because it is not fully active, then you'd like to strengthen the regimen using another drug, and here a combination of TDF and 3TC is actually a pretty good combination. Indeed, in this patient, we started the patient on TDF, TTC, DTG, plus darunavir. That brings us to the end of our session, and I'd like to invite questions. Thank you.
Thank you, Doc, for that presentation. So let's get those questions and comments from the team. Maybe I can start us off. Doc, now with the explanation of the cross mutations as the patient continues using the filling regimen. Do you think there is a room for maybe drug holidays for the patient so that the patient is failing second line? Adherence has been issued, you have not solved the issue of adherence, you give a patient a holiday for that for a period, then you solve the issues of adherence, then you bring the patient back to the...
Sorry, Chris. There's a lot of echo.
Yeah.
I think, Dr. Mary, can you please mute? Sorry, I was not getting you well. Please repeat the question.
So I'm asking, for those patients who are maybe a second line, they are failing, and you have issues with adherence. So is there a room for maybe drug for that patient so that you stop all the treatment, then you solve those issues, then you bring back your treatment when all the issues of adherence are sorted?
Thank you. That's a really, really good question. Patients who are failing second line and they have adherence challenges, and you don't want to switch them to third line because they are going to mess up the third line. So what options are available? So there is no right or wrong answer here. This is where you need to sit down and discuss. And I'm going to give you the pros and cons of each approach. So approach one, let's assume you decide, okay, let's maintain this patient on the failing regimen as we sort out adherence. And once adherence has been sorted, then we move to second line. But remember, the longer you maintain a patient on a failing regimen, the more mutations they accumulate, all right? And the more mutations they accumulate, the more likely it is to affect third line, all right? So in my opinion, if you think you'll be able to sort out the adherence maybe in a month or two, then you can argue that that is not a long enough time to develop quite a lot of additional mutations. and you may continue on the failing regimen. The danger of stopping a regimen is the virus will replicate unchecked. And when you have high viral loads, they'll destroy the CD4. When they destroy the CD4, the immunity of this patient, is further compromised. So sometimes the advantage of the failing regimen is, yes, we know it is not treating, but it is keeping this virus, instead of it being in the hundreds of thousands, probably it's in the tens of thousands. So there's some damage limitation there. But at the risk of additional mutations, can you stop? So then the question is, as you are stopping, because adherence is sorted out by ensuring the patient is taking the drugs. So if we stop, then how are we going to address adherence? I don't know if you get that point, because you need the patient to be taking something for you to say that indeed this patient is now fully adherent and I can switch him to something else. And that's why it's recommended to continue the failing regimen for around 3 months, hoping that in those 3 months, it's a short enough duration. It's a short duration. The patient is not going to accumulate more mutations. And in that period, you really sort. But this issue of continuing a failing regimen for a year, 2 years, 3 years, no, that one now it becomes a bigger hurdle as we will be accumulating more mutations.
Thank you, Doc, for that. Maybe from the chat, if there is any question, let us check. So from the chat, can see there's a Cairo Medical Center. That was a good presentation. Dr. Deitu, thanks, Doc, for the very informative presentation. Then Team Marina, thanks for the wonderful and informative. Could you share the slide so that you can share with our colleagues? This one will be done. Charles Anyonga, Doc, thanks for the wonderful presentation. So in such a case, is it okay to use a drug with intermediate resistance as long as you back it up with a strong active agent? Maybe you can respond to that, Doc, from Charles Anyonga.
Thank you, and I think this refers to the last. Yes, can you please enable screen sharing? I go back to the last case I was discussing. The answer is yes. And these are the cases that you have multiple drug resistance, and you only have all right. We go to the last slide. This one here. So yes, as you can see, this patient has, there are no NRTIs working. There are no NRTIs. And the PIs also, they have varying levels of resistance. So as I said, here we are going to choose the drugs based on which has the least resistance, or which has never been used before. Thanks God, at least for the foreseeable 1 or 2 future, the next 1 to 3 years, DTG has not been used in these patients who are taking second line or third line. So DTG, more often than not, will work. It's fully sensitive. Darunavir, ritonavir, even with low level resistance, will work. All right? Because when you double the dose, it's able to overcome that barrier. But as I said, because you only have one drug that is fully sensitive, I just don't want to give 2 drugs and one of them has low level resistance. That's where you choose a third drug which also has either low level or intermediate level resistance. In some patients, you might actually find that etravirine is fully sensitive. And I know cases where we have used etravirine in such patients. And because of challenges getting etravirine, you will find that tenofovir, more often than not, will also have intermediate resistance. And in patients who are fully resistant to tenofovir, this is because they have a K65. And when they have a K65, more often than not, zidovudine will be fully sensitive. You get that? So in such patients, personally, I'll encourage TDF3C-DTG because it's one pill and it has an NRTI backbone with intermediate resistance. And then you throw in your darunavir, ritonavir. And I think that is the regimen that we have been using in most patients in our MDT who have a similar presentation.
So, still on the charts. So we continue to plugins, our Casco. Then thanks Dr. Nyukuri. Maybe let me look for questions for time. So there's a question from Marcy. So for the patient who are failing second line, who have not yet sorted their adherence issues and seem to be taking long, is it advisable to stop ART? I think you have answered that question. Maybe Dr. Mary Seritu. Currently, we are not receiving ritonavir from cancer for those on darunavir, and some patients cannot afford to buy. What is your advice on this? Maybe you can respond to that, Doc, or we go through all the questions, you respond them at once. Which one do you prefer, Doc?
Because of time, I just want, maybe I'll respond to this question by Dr. Mary. If there are any other questions, please feel free to reach out on phone, WhatsApp, a phone call, or email. I'm more or less available. So, Dr. Mary, this is a very challenging question, especially if the patient, if it's the DST we saw last, yeah, a patient who has only DTG as the active drug. I will not encourage us to give darunavir, ritonavir without boosting it. However, this patient has something that can work. You see here, lopinavir, ritonavir, right? It has low-level resistance. So it's something you can consider instead of using darunavir, ritonavir. We know a formulation of lopinavir, ritonavir exists. And yes, this is a patient I will switch to lopinavir, ritonavir, and then the DTG, and then DF3TC. And that's a pretty robust regimen. If the lopinavir, ritonavir is gone, then these are the patients I will say, let's discuss on a case-by-case basis and see what can be done. I don't think we'd like to generalize management of such patients. Those such kind of patients, it should be individualized and have a discussion with someone who has experience in managing patients with multi-drug resistance. Thank you. I'd like to leave and attend the other meeting. So thanks to all who have attended. Keep up the spirit, keep up the good work. This TWG is now how many years old? Started in 2017, 3 years old now. I remember when we started, our aim was, to have a pool of experts, and I firmly believe we have experts now in our midst. I remember the first time we attended the advanced HIV course. Quite a lot of this was Greek, even to me. And I'm happy that right now we can have a discussion around this, and it doesn't sound like Greek. So keep up the good work, share the knowledge, practice, consult. Thank you.
Thank you, Doc, for that presentation. And also, Dr. Nyukuri happens to be our co-chair with Dr. Deritu as our co-chair. So thank you for that. So the next activity of the day, we want to have a presentation from Sheila or Greg. But as we try to share, I will welcome Kiplagat to say hi to the team. So Kiplagat, I can see you on call, you can say hi to the team.
So thank you for this opportunity. I want to greet you. Good morning, all, and thank you for attending the TWG. And also want to thank Dr. Nyukuri for supporting us through this presentation. I think as mentioned that during our advanced clinical course, the issues of mutations, the terms, and all that was a Greek to us. But I'm happy that now we are discussing, and I'm looking forward to the discussions and also to participate fully, and welcome you all. Thank you, and back to you, Chris.
Okay, thank you, Kiplagat. We want to